Can you all see my screen?
Yep.
Okay, perfect. All right. Hi, everyone. As Rachel said, my name is Amanda Perino, and I will be presenting on my study that's titled Exploring Physicians' Response of Comprehension of and Response to Pharmacogenetic Test Results Used in the Psychiatric Setting. And thank you all again for signing in over Zoom. It's great having people to listen to our presentations. Okay, so an overview of what I'll be covering. I'll go over a background of what pharmacogenetics is, the aims of my study, the methods I used, the key findings, the discussion section, the main conclusions, and then some of the limitations of my study, future directions for other researchers, and then if you have any questions, we should have time at the end. So we've known for a while that people respond to medications differently. And some of those differences we can contribute to our genetics. So taking it back to high school biology, our DNA contains genes, and these genes have instructions that tell our body how to grow and develop. Some of these genes also contribute to how our body metabolizes and responds to drugs. So you can imagine that changes in these genes can lead to differences in response to medications. And then in psychiatry specifically, we know that genetic variation may account for about 42% of variation in antidepressant response. And this is really important because we know that nearly half of people with depression and anxiety don't respond to first-line therapies. So maybe some of this has to do with genetics. But then we also know that other factors play a role, such as epigenetics, which is how much the gene is expressed, so whether the gene is turned on or off. There's also our diets that influence how we metabolize drugs, as well as another disease that we might be diagnosed with. And then on top of that, we have drug-drug interactions. So if somebody's taking multiple medications, we know that sometimes they may influence one another. So what is pharmacogenetic testing? So for the rest of my presentation, I will be referring to pharmacogenetics as PGX because it's a lot easier to say, and that's what most people have agreed upon is the best acronym. So basically the test is a blood draw or a saliva sample, and it evaluates these genes that influence drug response. So there's two different types of genes. There's pharmacodynamic and pharmacokinetic. And really what this is doing is it's just describing what the gene does. So pharmacodynamic genes are really what the physiological effect of the drug is within the body. So it's ultimately the therapeutic effect that the medication has on the individual. An example of this gene, of a gene that contributes to this, would be SLC6A4.
When she's talking, she's good.
In contrast to this, we have pharmacokinetic genes, which are really having to do with what dose of that drug will produce the therapeutic effect. So pharmacokinetic has to do with the time course of absorption of the medication, the distribution, the metabolism, and ultimately the elimination of the medication within the body. So a subtle difference between them, both having to do with response to medications. And then this is just an oversimplified example. We have individuals in a physician's office that would go in to get a pharmacogenetic test to see what medication they might want to be taking. They would give their blood sample to the lab. They would then analyze their DNA, or more specifically, those genes that contribute to drug response. And then based on those genes that are analyzed, a patient can get multiple results. So, for example, they can have a result that indicates they need to be on a higher dose of drug X, or they can get a result that indicates they need to be on a lower dose of that same drug, or they can get a result that they need to be on a completely alternative drug. Again, very oversimplified, but that's the main gist. So more detailed clinical examples, we know that the cytochrome P450 genes are heavily involved in the metabolism of drugs. They're also involved in the synthesis of fats, cholesterol, and other steroids. And we know that specifically the gene CYP2D6 and a medication called amitriptyline, which is used to treat depression, we know that changes in CYP2D6 that lead a person to be an intermediate metabolizer, we know that amitriptyline is going to be higher in their blood, and therefore they might not need as high of a dose of the starting medication. So the recommendation would be to consider reducing amitriptyline by 25% due to this individual being an intermediate metabolizer. And then another example, very similar, in the gene CYP2C19, if somebody is found to be a poor metabolizer, this also results in higher levels of citalopram. And they actually can have a risk to have a QT prolongation, which is a very severe cardiac arrhythmia. So it's basically saying do not go over 20 milligrams of citalopram if someone is a poor metabolizer. So you can see how this does have clinical relevance and how pharmacogenetics can really help to appropriately prescribe medications. And here are some of the resources that come up with these guidelines. So number one being the FDA,
3 times in the
two
first
being the Clinical Pharmacogenetics Implementation Consortium, so CPIC, and then PharmGKB and the primary literature. You don't need to read all of these details on the side here. I just wanted to give you screenshots of what these clinical guidelines look like. So at the top is a screenshot of what's on the FDA's website. And you can see here the gene-drug interaction and then the clinical recommendation. And then at the bottom is a screenshot from CPIC, and there you can see the actual genotypes listed, what that means, and how that person is going to respond to the medication. Something really important to note is that the FDA very recently came out with a statement basically saying that they wanted all PGX labs to remove the clinical guidelines from their reports, because they basically said there wasn't enough high-level evidence to support these gene-drug interactions. And this was troubling to labs because, of course, this is how physicians interpret the results. But the FDA really did this to ensure that physicians were practicing safe treatment changes based on these results, and wanted to make sure that everything was based off of scientific evidence. So the aims of my study specifically, which were all limited to assessing PGX in the psychiatric setting. The first was to assess physicians' understanding of and questions about pharmacogenetic test results from the perspective of the PGX lab professionals, so the people offering the tests. I also wanted to identify challenges in the clinical implementation of PGX test results from the perspective of PGX lab professionals. And then lastly, I wanted to make recommendations for educating physicians on the implications of PGX test results for prescribing medications in the psychiatric setting. So my methods I'll go through pretty briefly. So it was a qualitative approach. So I used a semi-structured interview guide, and I recorded the interviews on my computer using QuickTime Player. My participants consisted of PGX lab professionals with experience answering post-test consultation calls from physicians. So if physicians had a question about the PGX test results, they would call these lab professionals to get answers. And these lab professionals were the people I was interviewing. And then I went through all of the transcripts. I coded, me and another researcher coded the transcripts and came up with main themes that were relating to the questions and concerns voiced by providers, as well as themes relating to the clinical implementation of PGX testing. So here is just a brief table of the demographics of my participants. You can see that many were doctors of pharmacy. I had 8 participants in total. One was a PhD in neuroscience, and another was a medical doctor, and another had an associate's degree. About half and half were male and female. Many had formal PGX training, and many had clinical experience as well. You can see the average number of consults that they took per week. You can see their time at the company, and then you can see their job title, which most of them were in some sort of management role. It's also important to note that interviewee 008 was not from a PGX testing company, but rather from a community health system, which is a little bit different. But he was still answering post-test consultation calls. Okay, so moving on to my results. Most reports I found were returned directly to providers before they were returned to patients. So providers had to get the results before patients could see their results. And then I found that all of these post-test consultation services were free of charge to providers, and they were offered by all labs and community health system. And then the content of the report that the physician received was variable. And this was based on feedback from providers and FDA recommendations. As I mentioned before, the FDA recommended for the PGX labs to remove all clinical guidelines. So, of course, their report is going to change. All labs provide information about genes and variants on the report, as well as the genotype's effect on the response to drugs. So they'll list the gene, they'll list the variant, and they'll list what that is. So either a slow metabolizer or a poor metabolizer. But then, in addition to that, labs disregarding the FDA recommendations continue to report these gene-drug interactions and clinical interpretations, which include many psychiatric medications. So labs following the FDA don't necessarily list medications, whereas labs not following the FDA are listing these medications and these clinical interpretations. And then at the bottom is just an example of the what a clinical interpretation would look like on a report. Okay, so my interviews ranged from 42 to 61 minutes, and I identified 3 main themes with some sub-themes in those main themes. The first theme was limitations in reporting and interpreting of PGX results leads to physicians' questions and concerns. The second theme was providers ordering PGX tests need additional education, and clinical implementation of PGX will be challenging.
People come
So I'll try to go over these pretty briefly.
No big deal.
So the first theme, we found that most physicians had questions and concerns relating to how to apply the results to patient management. So I think a really good quote that illustrates that is, providers don't even care about the genetics. It doesn't matter to them what genes were tested or anything. All they want to know from this report is the drug or disease implications for this thing. So it seems that providers really just wanted a clear-cut answer as to what medication this patient should be on based on the test. But I found that there were many limitations in reporting and interpreting of the PGX results that led to not so clear-cut answers. Other providers with more experience would ask scientific questions, so they would ask about variants and specific genes. But some participants noted that the consultations mainly focused on just explaining the results in general terms. And then some participants noted talking about the clinical history of the patient during the consultation. So what diagnoses they had, so whether it be OCD or schizophrenia, and then also talked about what medications they have tried in the past, because that definitely can contribute to interpretation of the results. Okay. And then my next sub-theme was that reporting of results for PGX is very complex. And it's due to what I kind of boiled down into these 4 reasons, which was uncertainty in reporting exact risk of developing a certain adverse drug reaction. So for example, that QT prolongation, so that heart arrhythmia, there's no way to predict what the likelihood is of a person developing that. Is it 30? Is it 50? Is it 60%? Those numbers are very different. There's also an increasing number of genes and variants associated with one medication. So as we do more research, we're going to find that more genes contribute to drug response than we originally thought. There's also the variability in the degree to which patients' clinical history should influence result interpretation. And then, of course, considerations beyond gene interaction. So drug-drug, a person's diet, a person's diagnosis. And then we also found that interpretation of PGX results differs between labs. So this also can be challenging for physicians. There's no standardization among what genes and variants should be included on a report. And the clinical recommendations among labs for the exact same variant may actually differ. And that was part of the reason why the FDA came out with that statement to try to standardize things. Theme 2 is really straightforward. I found that providers ordering PGX need additional education. So my participants noted that clinicians typically don't recognize other factors that are influencing medication response in addition to the PGX results. But all participants acknowledge that it is their job, so the PGX lab professional's role, to educate these physicians. So I think this first quote really summarizes it. I think that a lot of providers haven't really had the opportunity to be educated on this in medical school, and so I think that is one of our main jobs, is to help them with clinician education. I think this is getting better, and I think they're starting to incorporate PGX education into medical school, but of course, you're going to have the older generation of physicians that have never heard of this word. Okay. Theme 3, clinical implementation of PGX will be challenging. I think we can all acknowledge that PGX is not mainstream. Some people probably have never heard of it before. So we really need more data on the clinical utility, how pharmacogenetics is going to help with patient care. So many of the participants suggested large randomized clinical trials, and others suggested that once we have these large clinical trials that show clinical utility, it might actually encourage the insurance companies to cover PGX. Because that's another problem. This testing isn't universally covered by insurance companies. So, of course, that's going to be a barrier to clinical implementation. And then you can see this nice quote. Basically, the study or clinical trial has to show that, hey, if you use PGX versus patient care as usual, you can improve patient outcomes or prevent serious adverse reactions. Okay. Another factor that we found that will make clinical implementation challenging is that the standards of clinical evidence used by labs varies, and this actually leads to different clinical recommendations. So some of the participants noted that there was a lack of standards as to what level of evidence is needed to drive clinical recommendations. So there's really no quote-unquote gold standard test. And I think this is a really strong quote. Remember, pharmacogenomics has to do with the clinical level of evidence. So just because there are 20 genes associated with one medication that you might be taking, that doesn't mean that all those 20 genes should be reported. So emphasizing the fact that some genes contribute more heavily than other genes. And then, pretty self-explanatory, physicians have very busy schedules, and implementing this into their daily practice is going to be challenging because they don't have enough time as it is.
No parent
So adding another step and adding this interpretation of the PGX results is going to be challenging for them. So briefly going over the key findings, we found that most clinicians had questions regarding the implications of PGX results for patient management. We also found that many clinicians have unrealistic expectations of PGX and believe the test will provide them with a quote-unquote next step solution, which typically it does not. We also found that many clinicians are unaware they need to incorporate the clinical history of the patient into interpretation. So therefore, with all of this being considered, ordering clinicians need more education. There are going to be many challenges for clinical implementation of PGX. And we also found that due to this lack of education, there might be a potential role for genetic counselors in educating physicians and the public on PGX. So my conclusions are that providers often appreciate the value of PGX, but there are still so many limitations regarding reporting, interpretation, and clinical utility of results that they're unsure of how to use it. These limitations revealed why the physicians have questions regarding the results, reservations about ordering the tests, and difficulties interpreting. Suggestions for improvement include clinician education, data on clinical utility, improved insurance reimbursement, and better ways to incorporate testing into workflow. So very briefly, my limitations were a small sample size of 8, and since we were talking to participants that took post-test consultation calls, there was no way to determine how clinicians understand PGX results who aren't asking post-test questions. So they might understand it completely, or they might still be challenged, have a challenge in interpreting it. And then also PGX has applications in many other settings, such as cardiology and oncology, so that's other areas where it can be explored. Future directions, more studies that directly assess provider knowledge and provider utilization of PGX, as well as how providers understand and act on results. And then we could also have more studies that identify potential roles for genetic counselors in PGX.
That's our conclusion.
And I would like to thank all of the mental health professionals out there, as well as my family and my classmates for supporting me through this entire process. And I'd also like to thank my thesis committee for supporting me and giving me great edits and really helping and motivating me to finish this project and do it the best to my ability. And I have no potential conflicts of interest. So does anybody have questions for me?
Yes. And this is Dr. McHugh. I work with Rachel, the medical director over at Mainline Health. I know many of you have rotated to our center. And a great presentation. The limitations really do exist with the lack of clinical trials and really understanding the FDA asking to take guidelines out when you can't support that data. We do pharmacogenetic testing in patients who have severe reactions to chemotherapies to say perhaps that was the reason behind it, and sometimes we'll find out they are a core metabolizer and we'll avoid that drug. But if we were to test so many people, we would find that they do have deficiencies and can tolerate a drug that could be life-saving. So it's really difficult to interpret this information in the clinical world when we're taught and it's built into our head. Everything needs to be evidence-based. So trying to find out that perfect balance of when do you use pharmacogenetic testing in the medical community.
Yeah, and that was definitely, that's a great point. That's something that we kind of found among all of my participants. There was really no one person saying, this is when physicians always order it in a psychiatric setting, after patients have failed this many medications. There's really no guidelines on what patients should be offered it, specifically in the psychiatric setting, and I think that leads to a lot of misconceptions about it.
Amanda, great presentation. Do you think that genetic counselors have a role in, PGX testing, and do we need what kind of extra education do you think genetic counselors could pursue if they were interested in joining a part of the PGX world? Because I feel like what I know of PGX is from what you've passionately told me about, and it's not something that at least I have learned in some of the core courses. It's kind of just been on the periphery. So what would you say is the role of genetic counselors in PGX testing?
Yeah, that's a good question. I think it really depends on the person and how much someone wants to dive into pharmacogenetics, because of course it's not typical for genetic counselors to be interested in it. But there is that genetic component, so I think we can contribute to it in some ways in an educational role. For opportunities for learning more stuff, there are numerous webinars that are hour-long talks by people at Stanford that do pharmacogenetics for a living. I think those are really great. There's also resources on the websites that I put up on my presentation, like CPIC and FDA, to kind of just learn about how they're writing the clinical interpretations and how they're figuring out what variants make someone a poor metabolizer or an intermediate metabolizer. So I think those things are good to use.
You could have a camera.
And then, of course, I did a week-long rotation in a pharmacogenetic testing lab, and that was a great experience. So I think if genetic counselors are fortunate to have that, that's another thing that I think can expose them.
Great, thanks.
I had a question, Amanda.
Any other questions for Amanda?
I had a question. I thought it was really interesting that there's no standard test. And I was wondering if this is something that they're thinking about doing or developing, a gold standard test.
Yeah, that's a great question. I think the FDA guidelines were kind of put out there to kind of get people thinking that we should have a gold standard test, because there's so much variability between the assays, what genes and variants are on them, in addition to the clinical interpretations are so variable. So I don't know if they are moving towards thinking about getting a gold standard test. I know that each lab that I did interview seemed to think that their test was based off of evidence, yet all of those labs differed. So I think ultimately at the end of the day, it might come to any genetic test. Some labs want to have 60 genes on the panel, whereas some labs want to have, 15 genes. So I think it is going to ultimately go down to lab preference, but I think there is going to be a push for standardization of clinical evidence.
So she's fine. I think that's why they left her go.
Yeah, so Amanda, you have some really interesting data from the people that you interviewed, and while so much of it targeted your question, there was also quite a bit of it that targeted, just their own, these lab professionals' own opinions about PGX and opinions about utilization. That I think, if we were considering further studies, it would be so interesting to obtain opinions from all of the different players regarding this, because there is no standard right now, yet it's available, which I think, adds in a whole layer of complexity to consider. So you've got some really, really good stuff in there to look at further.
Thanks, Aisha.
I had a quick question, Amanda. That was a really great presentation. I just was wondering if you found any information in terms of patient consent, because I feel like patient consent, that would kind of force providers to know more about the tests that they're ordering and kind of the results they get back. So did you find anything in the realm of consent?
That's a great question. So you would think that if they had to go through a whole consent form, they would be informed about what the results tell you. But I actually found that one participant in particular said that these tests are often patient-initiated. So the patient doesn't even really want to sit through a consenting process, because they pretty much already decided look, I'm at my last leg with trying medications. Let me suggest this pharmacogenetic test to my doctor and see if they'll order it for me, to see if they'll get an answer. And most of the times, as I found, it's not really giving them a clear-cut answer. So I actually think a consenting process would benefit pharmacogenetics.
Gotcha.
Yeah, and I'm sure they have to sign like something
Right.
at the end when they send in their sample.
Yeah.
Formal consenting process, and it didn't really get discussed in many of my interviews.
Okay, cool. Thank you.
Yeah, good question though.
Just calling you.
Anybody else?
All right, thank you very much, Amanda. Next up, we're going to hear from Kennedy Richardson.